thank you for joining us, QC members and guests and colleagues. My name is Tricia Glass. I'm Executive Director at Quiet Communities. It's great to be with you this afternoon for our fourth QC Close-Up member event. Today, we will be discussing the impacts of noise on cardiovascular health. These QC close-up events are designed to give members an inside look at our work and access to important discussions about the value of quiet and the impacts of harmful noise. In a moment, I will introduce QC founder and president and friend, Jamie Banks, who will moderate today, and she will introduce our special guest, cardiologist, Dr. Michael Osborne.
Thank you, Trish, and welcome everyone. I am so delighted to have Mike here with us. He's really done some amazing research, and I'll just give you a quick window. Through his research, he's actually been able to image and show that when people hear noise, it actually lights up the part of the brain that's responsible for processing stress, emotions, fear, and so forth. So I'm really looking forward to his presentation today. Just to introduce him, Mike Osborne is a cardiologist at Mass General Hospital. He's the director of the Cardiac Positron Emission Tomography unit at MGH, Mass General Hospital, and is also assistant professor of medicine at Harvard Medical School. His research uses advanced cardiovascular imaging techniques to investigate the mechanisms linking noise and other stressors to cardiometabolic diseases. Using those imaging methods, he's shown that transportation noise exposure activates the neurological system and the stress reaction in the body, increasing the risks of cardiovascular events and diabetes. And with that, I'm going to hand you over to Mike.
Thanks so much, Jamie. It's an honor to be here and a pleasure to speak to all of you today. I sincerely appreciate your interest and look forward to discussing my work and the work of others that my work stands on with all of you. So I'm going to go ahead. Let me get my presentation to where it needs to be, and then I'll share my screen and jump right in. Okay. So let's see. Okay, so let me get it into presenter mode. All right, great. So yeah, so as Jamie explained, today I'm going to spend the first part of this this meeting discussing the research background of that we and others have worked on. So the title is How Noise Exposure Contributes to Cardiovascular Disease. These are just some acknowledgements to some potential disclosures as well as my research funding. So today I'm hoping to accomplish these objectives. I want to talk about the association between chronic stress and cardiovascular disease, talk about some of the mechanisms that underlie this relationship, talk about the impact of noise exposure specifically on these pathways. And then I want to bring in some more recent research where we've evaluated the combined effect of the exposure to noise and other environmental and psychosocial factors and how that may amplify cardiovascular risk, and also talk about some future directions. So first, I'm just going to talk broadly about some of the pathways and our understanding of how stress links to cardiovascular disease in order to set the table for what really led to some of our hypotheses around noise. So we know that chronic stress has an attributable risk for cardiovascular disease that's basically on par with that of typically recognized cardiovascular risk factors, including smoking, high cholesterol, diabetes. We've all heard people say, you know, you're going to stress yourself out to the point that you have a heart attack. Yet it's funny that stress itself is not part of the cardiovascular guidelines here in America. We also know that noise exposure itself is independently associated with heart disease, and it's most closely been linked to coronary artery disease, or artery disease of the blood vessels that supply the heart itself with blood. We know that stress affects a lot of things, and it's a very challenging thing to study because of that. It affects the lifestyle factors as well as drives hypertension, but these effects don't necessarily explain the entire relationship between stress and cardiovascular disease. So it argues that there's some sort of biological pathway that may underlie this, in addition to these behavioral and I guess, pathological effects that we're aware of. So we know that stress activates the stress response. So the key components of the stress response are the hypothalamic pituitary adrenal axis. And this is one of the systems in our body that allows us to release hormones in response to stress. So the primary hormone release there is cortisol. Other factors that contribute through this pathway include adrenaline, noradrenaline, all things that we've heard of. We also know that stress activates the sympathetic nervous system. That's the fight or flight response. So if you've ever been stressed out and started to feel clammy or the hair on the back of your neck standing up, that is the activation of the fight or flight response. And ultimately, both the release of these hormones and the activation of the stress of the fight or flight response triggers inflammation. The sympathetic nervous system actually directly plugs into our bone marrow. And when it's activated, we tend to produce more white blood cells. And these white blood cells go out in the periphery and just run amok and release all sorts of pro-inflammatory chemicals and create inflammation in a variety of tissues, including the arteries. So taking a step back, we know that stress is a unique thing, just like noise. Certain people find things stressful that others would seek out, right? We're not all going to go jump out of an airplane with a parachute, but some people would look forward to that. Other people would rather do just about anything compared to that. So there's this stressor, and then there's how our body responds to it. So it's really a dovetailed combination of these two factors that lead to cardiovascular disease risk. You have to have a stressor that you respond adversely to. And you can think of noise as a model for this. You know, the type of noise that I always think of is if you live next to a concert venue and you hate loud music, well, there's people paying money to go see that loud music that are obviously not stressed out about it. So it is sort of a nice balance to understand how some people find things stressful that others do not. And it's really the people that find a stressor stressful that are at the most risk as a consequence to that. So the question remains, how does stress get under the skin? So we, you know, my mentor, his name is Ahmed Tawakal at MGH, began to be interested in sort of understanding the neural networks that allow stress to enter the system. So it makes sense that we would all initially experience stress in our brain. So one of the primordial structures that's preserved in a lot of organisms that triggers the fear response and allows us to experience stress for better or worse is something called the amygdala. And the amygdala is a bilateral structure that's in the brainstem. It's named for the Latin word for almond because of its shape. And we know that it participates in the emotional and physical response to stress and fear. Now, the amygdala itself is regulated by higher tissues in the brain. So, for example, humans were lucky to have a robust cortex, which is the upper part of our brain that allows us to have more reason and regulate fear. So I explain the amygdala thinking back to my old time in medical school when in neuroscience, when they explain the amygdala to us as a structure that when it's preserved, a monkey would never go near a snake. However, when they destroyed the amygdala in monkeys, the monkeys actually sought out the snake and went to play with the snake. So they didn't really have the ability to experience that innate fear that monkeys are born with. Whereas, you know, I sort of explain the interplay between the amygdala and the cortex as if you were sitting in your house and you saw, again, just throwing this out there, a tiger walking down your street. Your initial response might be, oh my gosh, but fortunately as humans, we could rationalize and say, okay, you don't need to freak out. That tiger's not going to be able to get into your house. And that's the cortex's effect on the amygdala. So it's really this balance of the amygdala to the cortical activity that regulates how we respond to stress and fear. I hope that makes sense. So here's another illustration of that. Basically, what I would say is when the amygdala is dominant, we act out of fear, and that's really called more more bottom-up thinking, where the amygdala is a driver. So that is where you're having a heightened stress response to whatever it is that's stressing you. Whereas if you're more of a top-down type paradigm, where the cortex is outweighing the amygdala, you may be able to rationalize your stress, and you may not have as adverse of an effect from that stress. So this leads to some of the work that we've done to parse out how to better understand how stress gets into the system. So what we have used is this positron emission tomography, which is a molecular imaging technique that uses radioactive tracers. And one of the common tracers that we use is a radioactive sugar. So when we inject this, it goes to all of our cells in proportion to the metabolic activity of those cells. So for example, in the brain, it will go to all of your brain centers, but if your amygdala is more active, you'll have relatively higher uptake in the amygdala compared to the other brain tissues. Whereas in somebody who has higher cortical activity and may be able to regulate their amygdala a little bit better, they're going to have higher cortical metabolic activity. So we've come up with this paradigm of a measurement of brain activity that looks at the ratio of activity of the amygdala to that of the cortex to come up with a value that we have called stress-associated neural activity. So those people with a higher ratio tend to have a more dysregulated amygdala, whereas those with a lower ratio tend to have a more regulated amygdala and are more consistent with this top-down thinking. So the other beautiful thing about positron emission tomography is we get a whole body picture simultaneously. So we not only get a picture of the brain, but we also get a picture of inflammatory tissues. We get a picture of the arteries. This is a clinically used tool that we often use to evaluate patients who might have cancer, because tumors are very avid for this glucose. So we can often find, whether they've had cancer that spread or where that tumor might be, and it'll give us insights into the biology of that tumor. But for our purposes, we're using it mostly for research to look at the activity in this diverse range of tissues simultaneously to understand the interplay between those tissues. So how does the tissues inform us? So we have prior work that has shown that plaques in arteries, large arteries, because of the resolution of PET imaging, inflamed plaques tend to have a higher degree of uptake of this radioactive sugar, which is called FDG. So we know that inflamed plaques are more prone to rupture, to leading to heart attacks and stroke. So what we've been able to do is use this positron emission tomography to image individuals with plaque to get a sense of I guess the risk associated with those plaques. So this curve right here basically shows that the higher their measure of plaque activity, which would be this red line, the more likely individuals are to have an adverse cardiovascular event. So again, more inflamed plaque, more risk for cardiovascular disease. So again, Dr. Tawakol did this initial work where he looked at the activity in the brain, namely this ratio of amygdala to prefrontal cortex activity, and saw how it associated with other findings in the body at the time of an individual's imaging. So in a small cohort, they gave individuals a perceived stress survey. So that basically asks you about your stress at the time of imaging. And we found that there was indeed a significant relationship between perceived stress and this amygdala activity. We also see that among individuals with higher perceived stress, they tend to have higher inflammation in the arteries. They also have higher levels of a biomarker of inflammation, systemic inflammation called C-reactive protein, that we know is an independent predictor of adverse cardiovascular events. So it really seems that stress itself, and we're not the only people to see this, not only associates with this brain activity, but also downstream inflammation throughout the body and specifically in the arteries. But how do they all tie together? So when we look at the relationship between activity of the amygdala and activity of the bone marrow, which is the site where white blood cells are produced, we see that there's a significant relationship between those values. So the more active your amygdala is relative to the cortex, the more active your bone marrow is. And similarly, the more active your amygdala is relative to the cortex, the more inflamed your aorta is. So those are important relationships to keep in mind. And then notably, when we compared the activity of the amygdala to a tissue where we didn't think there would be a relationship, we just used subcutaneous fat as an example tissue here, there was not a relationship. So it argues that there's some pathway of association between this brain activity and these other activities in different organs. So looking a bit further, we looked at the impact of this amygdala activity, or what we have now called, I'm going to start calling it stress-associated neural activity, because I think when we call it amygdala activity, it minimizes the impact of the cortex, which we have found to be really important. So when we look at this stress-associated neural activity, individuals with higher stress-associated neural activity, again depicted by this red line, have a much higher risk for adverse cardiovascular events over 5 years than individuals with lower amygdala activity. So it argues for this paradigm, a pathway, wherein stress activates these parts of the brain, leading to this imbalance in neural activity, which then triggers the bone marrow to release more white blood cells. They go out to the periphery, lead to plaque formation, and ultimately cardiovascular events. So how does noise fit into this? So noise, as we know, has repeatedly been associated with both cardiovascular and metabolic disease and epidemiologic stressors, epidemiologic studies. We know that noise often occurs with other psychosocial and environmental stressors. So for example, there's often overlap between noise and socioeconomic deprivation, as well as air pollution. Most of our noise studies to date have involved the use of transportation noise because that's what's most readily been measured. More recent data and growing data suggests that nocturnal exposure and noise that results in annoyance may be unhealthy, may be more unhealthy. However, it's important to note that some of our findings show that noise exposure itself is independent. The cardiovascular effects of noise exposure itself are actually independent of annoyance. So it's both noise exposure and the annoyance that seem to combine. And again, going back to that paradigm, if you have both a stressor and an adverse response to that stress, you probably have the worst outcomes related to that exposure. We know that noise triggers the stress response. We also know from basic science studies that noise contributes to blood vessel dysfunction, higher blood pressure, worse sugar metabolism, and ultimately artery disease. So one of the leading groups in really the, I would say the founding father of noise research with cardiovascular disease is a scientist named Thomas Munzel in Mainz, Germany. And he did 2 important studies where he showed a population with known or high risk for coronary artery disease to nocturnal noise. And he evaluated their their vascular response with this technique called flow-mediated dilation. And he showed that individuals with coronary artery disease had a significant impairment in their vascular function after noise exposure. So they did a night where they exposed them to noise and a night where they didn't. And on those nights where they had noise exposure, their blood vessels became less reactive. Importantly, this particular study here showed that these noise effects were independent of both sleep disruption as well as perceived annoyance from sound. So it was the noise itself that appeared to trigger this relationship. They then looked in a healthy population and they found that there was a dose-dependent effect. So there was no noise in the control group. There were about half as many noise exposures in the noise 30 group as there was in the noise 60 group. So they found a graded effect in both vascular function and in adrenaline release in a healthy population with these variable noise exposures. So it seems like it affects both people with pre-existing disease, and it may have a greater effect in that group, as well as the healthy population. We also know from some interesting studies, including one that used a dental drill, that noise exposure alters the structure and activity of brain centers, including the amygdala. So we sought to test whether higher transportation noise exposure at someone's home address may act as an upstream driver of the pathway that we previously talked about, linking stress-associated neural activity to heart disease. So what we did was we leveraged a United States Department of Transportation noise map to measure the average transportation noise exposure, which at the time was roadway and aircraft noise, at each individual's home address. We were not able to account per se for time spent at work or time spent away from home, but this was where people were most likely to be sleeping at a given time. So we measured each individual's average noise exposure. And just to give you a sense, this is an older figure because the WHO recommendations have since changed. But basically to give you a sense of how low some of these noise thresholds are. So initially the cutoff for unhealthy noise from the World Health Organization was 55. And as you can see, just having a conversation is above that. But again, remember, this is 24-hour average. So if someone were talking all night, I'm sure, that could have adverse effects. But at a given moment, a 55 dBA sound is not alarming. This has since been reduced to 53 during the day and is now 45 dBA, which is somewhere between a quiet living room and a soft rainstorm, is considered to be unhealthy at night if it's your average noise exposure. So you can imagine living in a very noisy place near a highway, you're getting a lot more exposure than this. So what we found in our population was that when we stratified individuals by their noise exposure, those in the highest areas of noise exposure indeed had the highest level of this brain activity. Similarly, we found that those with the highest levels of noise exposure had the most inflamed arteries. So we then looked at the risk for adverse cardiovascular events using different thresholds. So here we used 45 and 55, and we found that individuals with higher noise exposure in both groups had a greater risk for adverse cardiovascular diseases. Unsurprisingly, this was higher in the group with even higher noise exposure. And we found that this particular relationship was independent of socioeconomic factors, healthcare access factors, other cardiovascular disease risk factors, what medications people were on, whether they had cancer or a cancer treatment history, their psychiatric history, and their air pollution exposure. So it really argues that noise is an independent driver of this pathway. So really, to sort of take that a step farther, because this was a retrospective study, to infer causation, we often use a technique called mediation analysis, which allows us to look at different pathways that may explain relationships. So in this, we hypothesized that noise exposure was driving the increased brain activity, which was then driving increased arterial inflammation and then leading to cardiovascular events, which we call MACE. And we found that this pathway was indeed significant. So it does seem that the whole sort of mechanism leading from noise exposure to adverse cardiovascular events involves both the brain and higher inflammation and disease activity in the arteries. So another study that recently came out, our work sort of corroborated a lot of the epidemiologic work that had shown a relationship with coronary artery disease and atherosclerosis. But a study that recently came out that leveraged the UK Biobank, which is a large biorepository in Great Britain, where people have been very deeply characterized. They have noise data on them. They have about 3,600 people who have had MRIs of their heart. What they showed in this particular study was that people with higher noise exposure, and they focused on aircraft noise here that was nocturnal, tended to have adverse remodeling of their heart. So they had larger hearts that were thicker and had decreased function. And this was across both thresholds of noise that they tested. So it suggests that not only is noise leading to artery disease, but it's also leading to contributing to heart disease and other forms, which in this case would most likely be would manifest as heart failure if these progress to a certain point. Some of our other work, we've been able to show that noise independently links to the risk for diabetes. It also independently links to the gain of visceral adipose tissues. So this is abdominal obesity, which is known to be pro-inflammatory. And we know that both of these pathways involve the brain. So again, thinking of that mediation model, you have noise leading to these adverse outcomes with the brain as an important mediator of those pathways. So again, thinking about the stress response, this isn't just leading to cardiovascular disease, but it's also leading to cardiovascular disease risk factors and other things that contribute to not just cardiovascular disease, but other disease states. In some recent work, we've tried to evaluate the effect of co-exposure. So one of my colleagues, Dr. Shadi Abahasham, led a study where he looked at the combined impact of high transportation noise exposure and low socioeconomic status. And he found that individuals with both exposures compared to one or neither exposure had even greater elevations in this abnormal brain activity, greater increases in inflammation of the arteries, and a greater risk for adverse cardiovascular events, really suggesting that individuals who have more than one adverse exposure may be at even greater risk for some of the adverse effects of noise. We also, in another study, looked at the impact. This was also done with Dr. Abahasham as my co-first author. We looked at a similar paradigm with air pollution. Notably, air pollution doesn't impact the brain. However, where air pollution sort of converges with noise pollution when there's co-exposure is in the arteries. So we found that individuals with both exposures tended to have higher artery inflammation than those with one or neither exposure, and also had a greater risk for adverse cardiovascular events. So it suggests that the same pathways may be involved in a variety of different I guess you could say psychosocial and environmental exposures that can lead to cardiovascular disease. And then I just want to highlight some work that's recently been done by Dr. Fatima Saeed, who we're lucky to have in the audience today. But she's looking at some other aspects of the impacts of noise exposure on cardiovascular disease. And she has found that individuals with pre-existing anxiety and depression tend to have a more adverse response to higher noise exposure. So if you have pre-existing conditions that may predispose you to having higher levels of stress. These individuals, when they're exposed to noise, have higher brain activity. They also have higher systemic inflammation and higher levels of autonomic dysfunction, as well as higher risk for adverse events. She's also been able to show that noise exposure by itself independently leads, and we've known that there's an association between noise exposure and cardiovascular disease risk factors, but we haven't necessarily figured out the relationship with the timing. So not only did she show that, as we would expect, that individuals with higher noise exposure have a higher incidence of these cardiovascular disease risk factors, they actually develop them sooner. And this more rapid development of these cardiovascular risk factors mediates the relationship between noise and cardiovascular disease events. So it really suggests that there's multiple pathways at play, but they involve, sort of the gain of cardiovascular risk factors, inflammation, autonomic dysfunction, all sort of culminating in cardiovascular disease. So that's sort of where the research stands from a transportation noise standpoint. More recently, a number of other types of noise exposure have sort of come to the forefront, and there's not a lot of data about these. And I think this is one of the gaps that needs to be addressed in future work. So pickleball noise is gaining a lot of, I guess, notoriety for individuals who feel that they're adversely affected by pickleball noise. So it's an impulsive, repetitive noise that really is associated with a high level of annoyance. So it's not necessarily the same type of noise as transportation noise, which is more continuous and intermittent, but it's these very rapid, incessant sort of popping sounds. And we also think that decibels may not be the best way to measure this, because if you take an average decibel, these particular pickleball sounds are only a fraction of a second. So the average is actually quite low. So there's been a suggestion that there should almost be, for lack of a better term, almost a tax where we up the intensity of this type of sound in order to compare it to some of the sounds that we have more research on. We do need more health research on this. There was a small study that showed that pickleball noise may be associated with higher cortisol levels, but it really hasn't been studied in great detail. So this figure, again, is something put together by Thomas Munzel years ago, but I think it summarizes the pathways that we think link noise to cardiovascular disease pretty well. The one thing sort of missing here is the brain, which I would probably put somewhere between the blue and the red. But it really, I think of the brain as sort of summing the effects, I guess the stress effects of noise. So you can think about disturbance in activities, sleep, annoyance, your emotional responses. That's all sort of summed by the brain. Once the brain, sort of establishes its value, that then trickles down to these other systems, including the stress hormones, systemic inflammation, autonomic imbalance, that ultimately leads to the formation of plaques, and cardiovascular risk factors, and ultimately leads to overt disease. So I hope that a lot of that wasn't too in-depth, but and I hope it was clear, but I'm happy to field any questions about any of that. But I do want to, before wrapping up, I want to talk about some future directions that we're thinking of. So a lot of our research to date has been retrospective, and there's inherent flaws with retrospective data that prevent us from saying that something is actually causal. We can often, say that something is associated, but we can't necessarily say that the relationships are causal. So we do want to perform a prospective study where we're measuring noise in real time, not necessarily using a model, and seeing how people's brains may respond. We also have taken a pretty minimalistic look at the brain where we're really focusing on two centers. Some of our other work has taught us that these are not the only two important centers in understanding the relationship between stress and disease. So some of that other work may allow us to do that as well. We want to assess the impact of noise with different sound characteristics. I mentioned pickleball, but also low frequency noise is an area that needs more research, especially in the age of Bitcoin mining. We really need to go beyond dBAs to fully understand noise effects. I'm personally interested in whether individual or broader mitigation techniques can actually attenuate these pathways. So we know there's an association, but we don't know if someone wears earplugs and dampens their exposure to noise, whether they can actually lessen these adverse effects if they're annoyed by noise. We also don't know if strategies that might allow someone to better tolerate their noise exposure, such as stress reduction that can train you to not have as adverse of a response to a stressor, or give you strategies to sort of break that stress cycle, whether that might be beneficial in people who are stressed by noise, who can't necessarily escape their exposure. And, thinking even farther, although this is, it's a reach to tell somebody that you're exposed to noise, you need to take this pill to reduce the effects of noise. That does sort of argue that there may be some potential for anti-inflammatory medications in individuals who don't have other options. So, for example, if you can't escape the noise, or if mitigation techniques or stress reduction techniques don't necessarily work for you, well, one strategy might be to take a drug that, like a statin, that would lower the inflammation in your arteries, regardless of the cause of that, to lower your cardiovascular risk. So in conclusion, stress contributes to the development of heart disease through a mechanism that begins in the brain. We know environmental noise exposure increases the activity of this pathway. And finally, in addition to policy changes and mitigation strategies, therapies targeting this mechanism should be considered to lessen the impact of noise on heart disease. So thank you all for listening. I'm certainly happy to take any questions and explain anything in further detail if anything wasn't clear. And sorry for the internet issue.
So Mike, thank you so much. That was great. And there's so much here to discuss that we don't have time to discuss today. But I think I'd just like to kick off the questions. In regard to environmental noise, so many of the sources have noise that have strong low frequency components, and you touched at that at the end. And strong low frequency sound components travel over long distances because they're poorly attenuated. They readily penetrate walls and windows. And there's a lot of indirect effects that can occur because of that. Besides, interrupting sleep, activities, there may be concern for family members. There may be stresses as to the value of one's property when one is exposed to chronic noise and cannot control one's environment inside, even after closing doors and windows. So it's a comment as much as a question with regard to that burden of stress that's produced by these kinds of sounds.
Yeah, no, I think that's a great point. I think, there's a lot of sort of indirect stress that relates from noise. And I think, one of the concerns there is that I sort of touched on is that noise often overlaps with other exposures, right? So you mentioned, sort of the loss of property value. Well, we know that, sort of adverse socioeconomic status. So if your neighborhood kind of goes downhill because of noise exposure, it looks like that's sort of a double hit, right? And that, suggests that those individuals might be at greater risk. I think a couple other things, that when you feel a loss of control, you're more likely to develop mental health issues. So you may develop anxiety or depression, and that combined with noise may not be a good thing. Or you're more likely to withdraw and not participate in outdoor lifestyle activities like exercise or exposing yourself to green space, and that may be more unhealthy. So I think we really do need to better understand different noise sources and understand not just the physical effects of noise, but the mental effects of noise. And it really, in a way, it argues for kind of a personalized approach to noise. So, we often don't talk about it in clinic, but when I have patients who come in and sort of say like the noise is really bothering me, we often think about, sort of strategies to tackle that. And I think that is where this may be headed. And thinking a little bit along those lines, some of the data that I didn't share, we did a study where we looked at individuals who all had high noise exposure. Now, some people who have high noise exposure have high brain activity, others don't necessarily have high brain activity. But those individuals that had high noise exposure but didn't have high brain activity did not have elevated cardiovascular risk. So it really argues that there's some combination of noise and that adverse exposure that's really driving this whole pathway. So not all people that are exposed to noise are necessarily at the same risk as others who are activating this pathway to a greater degree. And I think all of that needs more study.
So let me ask you one more thing, and I promise that I'll hand it over to the audience after this. You showed these survival curves showing different levels of average noise, 45 decibels, 55 decibels, and I just wanted to point out for the audience that that 10 decibel difference is perceived as being twice as loud when it's increased by 10 decibels. So 55 decibel noise is going to be twice as loud. And when you go to something like 65 decibels, you're talking about something 4 times as loud as 45 decibels. And just given the pattern that you're seeing, in those survival curves, what would you say about people that are being exposed to even those louder levels that are permitted by agencies like FAA?
Yeah, I mean, it would argue, and again, our samples beyond 55, we get really small. And it's surprising because, we this is a 55 average, right? But, Boston has several airports and we have a large population that's very close to Logan. And that's where a lot of our study cohort came from. But our population gets pretty small when we get to sound above 55, but all of the patterns sort of suggest that the higher the noise goes, the greater the risk is going to be. We did look at noise continuously in that study as well, so increments of 5 decibels. And with each 5 decibels, we did see a significant relationship with both brain activity and artery inflammation as well as cardiovascular events. So I would expect that as the noise continues to increase, we would continue to see those effects.
Okay, great. Thank you.
So there's a few questions. So
Yeah.
can start with Pamela's. So not especially
Yes.
anxious, tinnitus, noise. The question is, I have tinnitus and noise makes the left side of my face go numb and triggers trigeminal neuralgia. The stress of this does indeed affect my heart. Any suggestions for those of us with tinnitus, neuralgias, or migraines? So I think, these are all, again, manifestations of the stress response, right? We do not necessarily tinnitus, but migraines are something that is definitely related to the stress response. So I don't know of anything that's necessarily proven that can help, especially with noise, but I would say that any attempt that you have or any means that you have to lessen your exposure to noise or to train yourself to not be as stressed by the noise exposure might be beneficial. So one of the techniques that we're studying, not necessarily in noise, but in other forms of stress, is a stress reduction strategy that's given at our hospital. It teaches a variety of different stress reduction techniques, but we know that it has provided benefits in people with migraines. So if that sort of technique might help you better tolerate noise exposure, then that might be something that could be beneficial for you. Why is aircraft noise perceived as particularly disturbing? Is it the pitch of the sound? How does intermittent noise as opposed to continuous noise affect your findings? So we didn't necessarily look at, we weren't able with the data that we have to really compare intermittent versus continuous. But I think one of the things about aircraft noise is that it's really been the most widely studied. So in Europe, a lot of the data has involved studying flight paths, namely in London, and it actually led to some changes in how Heathrow operates. So I think aircraft noise is one of the probably the louder noises that we're routinely exposed to, which is why it has been looked at in that way. I think it's also something that, that happens, as you note, sort of intermittently. So it's something that you can't necessarily acclimate to. You might, again, if you're sleeping, and a plane flies over your house, it's more startling. Depending on how high that plane is or how low that plane is, it may have different qualities. So I think it's become more of a model for noise exposure because it's been so highly measured. But I do think the intermittent nature of it and the unpredictable nature of it is something that makes it somewhat more stressful. And I hope I answered that. Is there a plan to include people who do not consider noise to be stressful? Yes, and this sort of gets back to my in future studies, and this gets back to that study that I talked about how some people appear to be more resilient to noise exposure, right? So those people that are exposed to noise but don't necessarily have higher brain activity or have the adverse effects of noise, it's important to try to understand why that might be. And that may actually, and understanding those individuals and what their biology is might actually inform us on how to help people that are more stressed by noise. So yes, my answer to that is we are certainly trying to evaluate that group in future studies. Sandra's question is about how a local airport has begun to measure noise events. Tally of 41 over 65 dBA with an average duration of 20 seconds, really around the time that somebody might be sleeping at early morning or late evening hours, and how might that irregular input affect the noise response. I think, the irregularity of noise, I think, is really something that it kind of leads to annoyance because there's a lack of control, right? So you're in your home, it's supposed to be a safe space, you're being exposed to this noise, you can't necessarily control it. I think that's something that makes it really challenging. This notion of, oh, just wear earbuds. Nobody wants to wear earbuds when they're in their house. That's not what you're supposed to do when you're at home. So I really do think it's sort of that intermittent nature, that lack of ability to sort of prepare yourself, that disruption of your activities that occurs as a result is probably what makes that less healthy. Idea of percentage of people that tend to feel more noise stress versus those that don't. I think that's really challenging because of the definition of noise. I think, probably all of us in the entire world, there's some sound that we find annoying. So I think, the question would be whether there's particular sounds that are more annoying, and I think it's those that we have less control over that probably get to that. But I would say that the vast majority of people would find something that would qualify under the definition of noise as annoying. I don't know if, Jamie, if you have any other thoughts on that, but that's how I would think of that particular question.
Sure. I mean, what I would add to it is that, of course, the duration is going to make a big difference. If you hear something for 2 minutes, it's one thing. If you hear it for 2 hours, it's something else, if it's annoying. So, having it go on and on is going to have a bigger effect than something that is temporary.
Yep. And then there's a question about, thank you, Jamie, about could it be useful or helpful to frame annoyance differently in a more neutral way, especially for a lay audience that doesn't know that even people with low annoyance or no annoyance can be adversely affected by noise. Yeah, no, I think that's important. I think, I guess, the other way to frame annoyance would be you experience stress consequent to noise. Although I think it's, that's a much more broad term because, again, the stress experience is unique. But your point is well taken that it isn't just annoyance that's leading to this. But I think in all, we know that noise itself, even in the absence of annoyance, does have adverse effects. But it seems from from the work that I've seen, and we haven't directly measured annoyance because we've had retrospective data, but individuals who experience annoyance and in noise exposure tend to have a worse effect than if they were, say, not annoyed by that noise exposure. So I think the way that you could conceptualize that might be that if you experience noise and you have stress related to that noise exposure, it's more likely to be unhealthy. And again, that's irrespective of what the noise level is. So you could have a very quiet sound that you find annoying. That probably has adverse effects independent of the low decibel range. And then there's a question, impressive, these studies find statistically significant effects with high measurement error, exposure misclassification, definitely true. Any comments on where you would initially focus efforts to reduce this misclassification for future epi studies? So I think, we really need to, so those studies were basically, the map measures sound at the side of the home with the highest noise exposure. It's not the front door. It's not someone's bedroom. I think what you would need to do is measure in somebody's bedroom to best understand, what somebody's experiencing at nighttime. I also think some of these newer tools that allow you to measure noise in real time, even when folks are not at their home, to get their cumulative noise exposure, whether they're at school or at work, would also be helpful in sort of parsing out which type of noise is most unhealthy and to get accurate measures. So I hope that answers Jay's question. We've got the decibel level of blowers there. Migraines are not necessarily from stress. Tinnitus and hyperacusis are actual. Yes. No, I would agree. Okay, this presentation is geared too much towards stress, so I'm leaving. Okay, I'm sorry, she was unhappy with that. Okay, amazing talk with good data. Any data that you can share about white noise for AC that average about 55 to 60 decibels? Any data and measures in Boston area to mute EMT noise? Thanks again for this amazing presentation. No, thank you for the comment. So white noise, I think white noise is interesting because I think white noise might help some people, but other people might find white noise annoying. There have been some studies that have looked at white noise in a ICU setting. So, that's a place that we often think about patients being exposed to high levels of noise in a clinical setting, where they may have higher levels of noise exposure that may contribute to adverse health effects because of the alarms that they're experiencing and so forth. And they have done some studies where they have looked at white noise, and there is a bit of supportive data there. But I think it would again be interesting to know if that's a broad effect or if that's in individuals that actually find white noise helpful. There have been other studies with earplugs. There have been studies that have allowed patients to listen to music of their choosing. So I think any sound that might attenuate stressful or disruptive sound might be helpful for a given individual. Data or measures in Boston area to mute EMT vehicle noise. I don't know of anything in particular. I do know that the U.S. Department of Transportation map did account for high traffic routes that involved a lot of ambulances and sirens. So individuals that live closer to hospitals or police stations or fire stations did tend to have higher measures on those for their average noise exposure. But I agree, this is something else that's an intermittent sound that's quite loud and disruptive that we need to better understand how to deal with that. Jamie and I had an opportunity to Zoom with a European researcher who had been involved in the mouse studies that found the effect of the noise on the epithelial cells of blood vessels. Has anyone studied if the effect is seen if the hearing is obstructed or obliterated? I don't know. I apologize. I don't know the answer to that particular question. I will say that in human studies, and some of that data that I showed in the human studies, that individuals who had like a night where they were exposed to experimental noise, they had abnormal blood vessel function in the morning, even healthy people. Whereas if they had a night where they took that, where they withdrew that noise, so they had a control night where they weren't exposing them to any noise, the blood vessels actually went back to normal. So it would suggest that, if you take the noise exposure away or you take away the ability to sense that noise, that some of this may be reversible. Again, that's acute noise exposure, not necessarily chronic. So I think the question would be whether, you could take somebody who's been chronically noise exposed and get rid of, that noise, whether it would go back to normal. And that's one of our questions. We don't yet have an answer to that. I think acute noise, we suspect that those effects are more transient and reversible. And then Karen raises the good point that brown noise can be better and more calming, and I would agree with that. So, in our interventional studies, we're sort of trying to come up with an idea that's the most neutral. My initial thought would be to use earplugs. I know that some people find earplugs themselves annoying, but I worried a little bit about an initial proposal where we were assigning a particular type of sound as a personal mitigation, because some people again are going to find some sound soothing, and others are going to find that same sound not so soothing. So I didn't want to compound the problem, but I think all of this needs to be compared. And again, it may get back to the fact that different mitigation strategies may work better for different people.
Mike, thank you. Oh, wait. Yes, I see one more question.
Yeah, low frequency noise. I think this is really tricky, and I don't necessarily have a good answer for it. I think, the main thing is because of its ability to penetrate and its ability um, to impact people so broadly, that I really think this is going to be more of a policy type thing, where these places that are emitting this high levels of low frequency noise are probably going to have to come up with ways to better buffer the sound. And they're not going to do it volitionally, but we're going to have to try to advocate for the communities around these places in order to make sure that they're not exposed. I think the other thing is, from a policy standpoint, we need to try to minimize the time of day that people are exposed at their home. If it's a continuous sort of 24/7 onslaught, that's probably going to be a lot more damaging than, say, if it's for a short period of time during the day rather than at night.
Just add one thing. Low frequency noise is very, very hard to mitigate. So another thing that would be important is really to advocate for advanced technology solutions, for instance, with ventilation fans that minimize those low frequency components and, can help mitigate the problem. And there may be others as well.
Christopher raises a point that there's a FAA study looking at earplugs and other mitigation measures. Sally says, do you believe that noise is only internalized by hearing, or could absorption through the skin? So there's a possibility that vibration components may be involved as well. I think, again, what we have best right now is decibels. And I think, that argues more for a hearing effect. I would suspect that there's other non-auditory effects of noise, and certainly indirect effects of noise that we need to better measure. So yeah, don't have a great answer to that, but I think there's probably more to it than just ears. Can low decibel sounds but higher in frequency intensity be considered? Yes, that are acute and chronic. So again, that you could argue that that's definitely the case. That any noise is really anything that's unwanted or harmful. So regardless of what the decibel is, if it's unwanted or harmful, it can be considered as noise, and it could be unhealthy. And then there's a question about aircraft noise, low frequency. It does have low frequency components. A lot of the sounds that we hear have low frequency components, but it also has a high decibel range. And again, a lot of the studies that have looked at aircraft noise have sort of focused on decibels, but I think we need to gain a better understanding of the low frequency effects. And I think we're becoming more aware and getting better ideas of how to measure that. And then I guess this should be probably the last one, but
Yes.
developers and builders should design roads and layouts that would discourage racing, which produces noise that is not only loud, but especially ugly and aggressive. In nature, is this considered more nowadays? I would agree. I think we need to be very thoughtful, especially in Boston, all of these buildings are kind of coming up right next to highways. And I think as far as urban planning goes, we need to be more thoughtful about where we're putting a lot of our buildings, and the location of airports and train yards and train stations and highways when we go to redesign things, rather than building places of living right next to highways, if we really want to try to protect the populace as much as possible. I know it's going to be a challenge, and I think we have a long way to go from a scientific standpoint until we get to get to the point where people are paying attention to this as a risk factor.
So thank you, Mike, and thank you, Jamie, for moderating. Fascinating, and we're so grateful that we're here tonight and for your research. Everyone, I would urge you to kind of share more about what you learned here, and to share our newsletters, our briefs, our blogs, so that more people are in on this discussion about noise. And of course, follow us on social media. Have a terrific evening, and let's make the world a quieter place for everyone. We appreciate what you do. Thank you, Mike.
Thank
Thanks,
you.
Mike.
Thanks
It
again for having me.
was excellent.
Excellent. Quiet communities.